a 6-year-old quarter-horse gelding, cutting horse with chronic worsening left hind lameness that blocked out in the left stifle. This is an arthroscopy of that left stifle, and the initial appearance of the joint cartilage looks fairly normal in the medial-femorotibial joint. However, you'll see later that the cartilage is very abnormal. These are radiographs showing no bony abnormalities in this horse's left stifle. These are MRI images of the left stifle showing injuries to the craniolateral meniscotibial ligament, the caudolateral bundle of the cranial cruciate ligament, the joint cartilage of the medial and lateral femoral condyles, and a medial femorotibial joint effusion. The white areas of the green arrows are pointing to are the effusion in the medial femorotibial joint. This is the cranial lateral meniscotibial ligament injury. This is an ultrasound examination of the flexed stifle of medial femoral condyle showing moderate chondromalacia, which is soft, thickened abnormal cartilage on the major weight-bearing surface of the medial femoral condyle. This is the arthroscopy showing the major weight-bearing surface of the medial femoral condyle, and there is soft, abnormally thick, loose, fractured cartilage found when this cartilage is gently probed with a dull probe. Normal cartilage is very firm, it's much thinner, and it doesn't have fracture lines in it like this abnormal cartilage does. You can see the probe easily sinks into the abnormal cartilage with just light pressure on the cartilage. This is very abnormal. When we get to the normal cartilage to the left, you'll see that the probe easily glides across the surface of this normal cartilage with no sinking into the cartilage. Still evaluating this abnormal cartilage on the major weight-bearing surface. You can see these very abnormal fracture lines, very abnormal soft cartilage. And these are located on the axial 2/3 of the major weight-bearing surface of the medial femoral condyle. When I probe further left to the abaxial 1/3 of the medial femoral condyle, you'll see that the probe doesn't sink into the cartilage. This is very normal cartilage over here. And the meniscus lies right below that. Very normal cartilage here. This is where I've debrided some of the most badly damaged areas of cartilage, and now I'm performing microfracture on the subchondral bone through the damaged cartilage. And the tan areas there are exposed subchondral bone where I've taken off the worst damage. This is the lateral femorotibial joint of the left stifle. You can see the radiographs show no bony abnormalities here. I'm probing the cranial lateral meniscotibial ligament, and it has some soft longitudinal injured areas in it right there and there. Now I'm probing the caudolateral bundle of the cranial cruciate ligament, and now the cranial medial bundle of the cranial cruciate ligament. This is the cruciate ligament is encased in synovial tissue. This is the lateral femoral condyle. And I'm probing this, and you can see my probe is falling into these fractured areas of abnormal cartilage on the lateral femoral condyle. As we go further distal onto the major weight-bearing surface, you'll also see that my probe easily sinks into this abnormal cartilage on the lateral femoral condyle. Healthier cartilage more distal. Now I'm performing microfracture on the abnormal cartilage of the lateral femoral condyle through this abnormal cartilage. Microfracture facilitates healing of the cartilage by releasing some of their own intrinsic stem cells from the subchondral bone, as well as providing footholds for new cartilage growth. And when I put adipose-derived stem cells in the joint, these stem cells can also establish themselves in these pits and start producing new cartilage. This is just probing the craniocrucial ligament. Now we're in the medial-femoral tibia joint, probing the cranial medial meniscotibial ligament, where there's mild tearing, longitudinal tearing of this meniscotibial ligament. This is arthroscopy of the right stifle medial-femoral tibial joint. You can see the cartilage on first appearance looks relatively normal. There were no bony abnormalities of the right stifle seen on radiographs. This is ultrasound examination of the flexed right stifle, showing mild to moderate joint cartilage abnormalities of the medial femoral condyle just above the major weight-bearing area of that femoral condyle. When we probe this abnormal cartilage, we find that on the axial 1 to 2/3 of this femoral condyle, just above the major weight-bearing surface, there is this soft fractured abnormal cartilage found, less severe than in the more symptomatic left stifle. That's normal cartilage on the abaxial 1/3 to 1/2 of this right stifle medial femoral condyle. And you can see how easily the probe just sinks into this abnormal cartilage. And this is what's responsible for the lameness. It does not fix itself. This damaged cartilage will not repair itself without help. And this is just light pressure with the probe, and you can see how easily it sinks into this abnormal cartilage. Now we're getting a more normal cartilage as we go further distal onto the major weight-bearing surface. That's why this stifle was less symptomatic than the left stifle. We performed microfracture through the abnormal cartilage into the subchondral bone, again to release some of their own stem cells from bone and to provide new footholds for repair cartilage. This is the end result after we've taken off. We found a small area of subchondral soft bone and loosely attached cartilage that we removed. Now we're going through the septum between the medial and lateral femoral tibia joints to evaluate the lateral femoral condyle. That is just a small amount of blood on there. Found one small little area of abnormal cartilage that we performed microfracture through this abnormal cartilage. And then we inject adipose-derived stem cells and IRAP into the joints postoperatively.